I give a very warm welcome to all of you who joined in via Zoom, by the Zoom link we provided. And warm greetings from the studio. And it is a great pleasure to welcome my very good friend, Professor Jan Benes from Pilsen. We've been collaborating on the hemodynamic monitoring front for decades, and not by chance, but Jan Benes is also the current president of the SEPS East initiative that includes several Eastern European countries, and we are on a mission to link Western and Eastern Europe together and make patient care better and aligning with international standards here in Western Europe. So Jan, you've chosen a very tiny topic of basic cardiovascular pharmacotherapy. I hope this will, I'm sure it will be a nice fit to the 2 weeks ago lecture given by Xavier Monet. And for those of in the audience who will sit the Hungarian state exam in a month, listen carefully because there will be questions from this lecture on the exam. So Jan, over to you after this introduction.
Oh, thank you, Joel. I hope I will pass your state exam with my lecture. Okay, so greetings from Pilsen to all of you, and special thanks, Joel, and all the organizers for inviting me to this very interesting series of lectures. And yeah, I hope I will build on what Xavier told you previously. So today we will talk more about the topic of basic cardiovascular pharmacotherapy. First of all, of course, Jolt, you've just meant that we are working together on hemodynamic issues for decades, and you're right, it's 2 decades now. And over these decades, we've been, of course, working with different manufacturers of hemodynamic monitoring tools. So that's sort of conflict of interest. But I'll say that a bigger conflict of mine is that I am the head of the foundation course in hemodynamics. I'm the director of this piece in education given by ESICM, and I warmly welcome you or invite you to come or to connect to this, to be part of the foundation course. The issue of this year starts on the 10th of December, and it's still open, so you can join us to learn more about hemodynamics. It's a course given by or directed by Xavier, myself, Michel Chu, the current head of cardiovascular dynamics session of ESICM. So that's the conflict of interest, and let's go deep into hemodynamics. So when we are treating critical ill, we frequently have this amount of different drugs in front of us. We have to make the right choice. And what we'll discuss today is the reason to use some of these. What's the mode of action of these? What's the mode of administration? And it's important in all the drugs, in all what we are doing to a critically ill, we always have to mind that there is a collateral damage. And we should always use the least damageable thing, the least dangerous thing. So that's something we have to bear in mind when we are dealing with critically ill. But before we will go there, let's start with a bit of physiology. I'd like to stress that there are two sides of the coin in hemodynamics. The one side of the coin is flow. It ensures sufficient overall blood flow to the body. And you know that it's measured by cardiac output, which is a product of heart rate and diastolic volume and a left ventricle ejection fraction. So the stroke volume times heart rate. So that's the flow. That's one side. And there is the other side, which is pressure, which is usually relied to the cardiac output. That's also relied to the systemic resistance. And basically, body use the pressure to regulate, to direct the flow or to separate the flow from some organs into the other organs. So to let's say, to manage the appropriate flow into the organs it needs. So these are the two sides. And we know that for the flow, we have the job for fluids and inotropes. For the pressure, we have the jobs for vasopressors. So that's the first delineation we will work with. We talk about cardiovascular system. We always have to think about where are muscles in there. We've been taught that, or we usually, when we are talking about muscles in the smooth muscles, in the vasculature, we usually consider arteries. We know that they are elastic and they are the muscular arteries. And we usually say that the major portion of systemic resistance is within the muscular arteries. We frequently forget that even veins do have smooth muscles. And the capacity of veins is much bigger than the capacity of the arteries. Hence, the amount of volume which is stored within the venules and veins, which can be, let's say, put into the circulation by constriction of these, may be an important input in the beginning of the shock state. So what is to be stressed is that only capillaries, so capillaries are the only vessels not having smooth muscles. So these are the only vessels not responding to vasopressors. We'll get there later on. So that's another important issue. Also, it's important to consider the decrease or the decrement of pressures. We know that we've got systolic and diastolic pressures within the circulation. And then there is this drop, which is done by the arterioles. But there is also a flow within the veins up to the, let's say, the central venous pressure, the lowest pressure within the system. And this is manipulated by the constriction of the arteries and constriction of the veins. So these are the two modifiable places within the circulation. What else? When talking about physiology, we can have a local regulation. And from the point of local regulation, there is autoregulation, which may be even active, or which may be, let's say, passive, dictated by the metabolic needs of the tissue. For instance, muscles are part of the tissue which undergoes a huge metabolic, when in exercise, your muscles induce have high metabolic needs and increase by autoregulation its flow within the circulation. So there is a local regulation. And from the point of the tissue is somehow selfish. It just takes what needs and adapts the flow to its own needs. And then there is a global regulation. What has the body to adapt the local? What sort of substances has the body have to regulate the flow within its own? So mostly it's CO2 and O2 tension. On one side, constriction, one side vasodilating. It's also temperature. So again, that's the metabolic issue. And the production of adenosine is also a matter of vasodilation induced by metabolism. But there are other substances, you know, that these substances may be produced by inflammation, may be produced by leukocytes, or may be produced by eosinophils. So these are substances which can change the regulation within the local system, and they are meant to be locally active. And then we have a global flow, which is actually something distributing equally the flow and pressure within the body. So that's a global regulation of the system. And this equal distribution, or this set point, is dictated by the system of the cerebral regulation. So we should mind that there are baroreceptors. The body has receptors not for flow, it has receptors for volume in kidney and pressure within the vasculature. And all the systems go into the midbrain where something like pressure set point exists, which regulates the neuronal or neuroendocrinal axis of sympathicus and parasympathicus, renin, angiotensin, aldosterone, and vasopressin. So these are three major important axes which regulate the global flow and global pressures within the circulation. And hence, in order to regulate the global flow, the body has several receptors within the vasculature. For vasoconstriction, we have alpha-catecholamine receptors, we got vasopressin receptors, and angiotensin receptors. For there is one receptor for each of these axes. For vasodilation, we basically have one to be regulated. So mostly the body is set to be vasoconstricted, has more receptors for vasoconstriction, and there is only one for vasodilation. So usually the vasodilation is passive by the decrease of the vasoconstrictive tone. Of course, those substances we've been talking about, especially those who are produced by inflammation or anaphylaxis, so those produced under these circumstances, can spill off from the focus into the body and then can have a global effect and a global vasodilation. For instance, something we know as anaphylaxis. How does it look like? How does it work within the cell? So just imagine this is these are the two enzymes which help or which dictate the constriction of the smooth muscle. So it's myosin kinase and myosin phosphatase. So these are those, actually this is what's happening when there is a vasoconstriction, is a coupling of myosin plus actin and vasoconstriction. The most important receptor is alpha-1 catecholamine receptor, which is coupled with phospholipase C and calcium channels. So this is what happens in the smooth muscle of the vasculature: increase in endothelial calcium concentration, and via inositol 3-phosphate, increase in the activity of myosin kinase and increase in constriction. So that's the most important, let's say, pathway for vasoconstriction induced by catecholamines, induced by alpha-1 catecholamine receptor. I've been talking about the fact that you have catecholamine, you have vasopressin, and you got angiotensin. What you should know is that both these all these three receptors has the same pathway within the cell. So the smooth muscle cell has three different receptors for the same effector. So that's important. When we are triggering these receptors, they may be distributed unequally within the body, but all these three do act on the same pathway within the cell. There are some opposite. We've been talking about the opposite effect of beta-2 or beta-catecholamine receptor. They do block the, or they activate the cyclic adenosine monophosphate, which inactivates the myosin kinase and hence actually activates or increases the amount of myosin line chains and vasodilates the cell. So that's an opposite effect of the beta-catecholamines. And there is one more important pathway, and this is the nitric oxide pathway. This may be triggered by histamine, this may be triggered by kallikrein-kinin, and this is the production of nitrous oxide, which blocks or induces the change from guanylyl to cyclic GMP, and this increases the myosin phosphatase. So this is actually the effects of the vasodilatory pathway. When we are using drugs like phosphodiesterase inhibitors, we are vasodilating. We are vasodilating via increase in these CAMP and CGMP substances. So this is the way how we act here. And this is also why the phosphodiesterase inhibitors have some effect on the myocytes in the myocardium. What's happening in the myocardium is an additional effect. In the myocardium, this cyclic androgen monophosphate is actually not only dilating, it's acting more on the inositol triphosphate. So in the myocardium, the effect of phosphodiesterase 3 of these inodilators is slightly different, and it leads to increase in calcium channels within the system. And actually the effect of beta adrenergic receptors within the myocardium is similar to phosphodiesterase inhibitors. So this is what's happening in the myocardium, and this is why this system in myocardium increases the contraction, vice versa, unlike in the circulation. And we have also calcium sensitizers. So this is an overview of what's happening within the smooth muscle of the heart muscle cells. So that's our opposite, smooth muscle and the heart muscle cells. We have different substances, and these different substances may have different affinity on the catecholamine receptors. We've been speaking about alpha, beta catecholamine receptors. You know that they are even more separated. But for the clinical purpose, we can make a line between alpha activity and beta activity. So the more alpha activity you have, the more vasoconstriction you have, which is, for instance, phenylephrine. And the least alpha activity, the highest beta activity, like isoprenaline, then you have the even pronounced beta dilatory activity. So there is a difference of the different catecholamine substances to the catecholamine receptors. We will get there later on. Also, you have a different distribution of the receptors among the circulation. There are data pointing out that, for instance, vasopressin receptors are distributed more within the systemic circulation and within the gastrointestinal tract, but they are poorly expressed within the pulmonary circulation, which leads to the fact that if you are using catecholamines, you are increasing systemic vascular resistance, and you are increasing the pulmonary artery resistance in the same way. While when you are using vasopressin, you don't have the vasopressin receptors. The V1 receptors are not in pulmonary circulation, or not in that extent. So you are increasing systemic circulation, but you are not increasing the pulmonary resistance. So that's our different important differences between the substances. So I should summarize the physiology. So important is that we have these substances to reverse organ hypoperfusion. We cannot say flow is more important than pressure. There are two sides of the coin, and they are equally important. Important is that only capillaries don't have internal muscularis, so don't have the smooth muscle. They don't react on constriction. Several organs, most importantly brain, heart, and kidney, do have a local regulation. You have different receptors, but similar effector pathway. So what's been demonstrated for angiotensin, vasopressin, and alpha catecholamine receptor is the same effector pathway. And there is unequal distribution of receptors over the organs. And now let's go into the choice. So in order to make the choice, I've prepared several cases. I don't know if it's possible to vote, but I will still give you a piece of time to consider what you will do in the situation. So the first case to discuss is a med call to a 68 years old lady with chronic hypertension. And she's on the standard ward, admitted with the urinary tract infection. She passed emergency department with non-sustained hypotension. So she reacted to like 2 liters of fluid. And now you are called because there is hypotension, tachycardia, tachypnea. So she's 90 over 50, 110 a minute. She's having a peripheral line and she received antibiotics and 2 liters previously in the previous course. So we will agree on the fact that this is infection-associated hypotension. And the question is, what will be your treatment? So will you go for more fluids, that this lady needs more fluids because she reacted to fluids previously? Or will you go to any of the drugs we've been discussing? You got norepinephrine peripherally, you don't have central line, you go for vasopressin peripherally, for phenylephrine as an alpha mimetic or adrenaline. So let's start with these drugs. I won't let you vote, or I don't know, Jolt, if I may let you vote. First of all, let's hit the non-sustained hypotension. That's an important issue, and we frequently observe this. People admitted to the emergency department, they usually receive from the emergency, they usually receive like half a liter, 1 liter of fluids. Then you receive some fluids in the emergency department. And some of these people like reverse the hypotension. But we should always look on the blood pressure, which has been there before, and consider these patients very dangerous. Those who are non-sustained hypotensive in the emergency department may then in the course afterwards, when you send them, for instance, into the standard ward, they may develop hypotension again because of the vascular leakage, because of the leap in care. And the mortality of these people may be much higher. When we will go into guidelines, then you should not consider anything else than norepinephrine. So let's discuss why is norepinephrine the number one. And just to commemorate you, that's the alpha-1 agonist with a slight beta-mimetic activity. We can administer norepinephrine peripherally, so no need for a central vein, with at least in dilution. So it should be diluted. We know that 1 milligram in 50 mL is safe. From our own, we are using up to 5 milligram in 50 mL for several hours without having like extravasation, without having gangrenes. Literally speaking, so evidence is that 1 milligram and 50 mL, so 0.02 milligram per milliliter dilution of norepinephrine is pretty safe into periphery if you have at least 20 gauge peripheral needle, and you can administer it up to 24 hours. That's based on literature. Of course, you should observe the insertion site. I've been telling you that we've got alpha receptors even in veins, and these are data coming from Xavier Monet, who've been having the lecture previously, that norepinephrine does have a potential to increase the vascular tone and increase the loading conditions of the heart, but only in some sort of people. If you have someone who is septic, he is usually operating on the low arterial tone part of the compliance. And in these people, if you increase the arterial tone, if you increase the tone within the circulation, then you will decrease the amount of fluids you need. If you have someone who is hypovolemic and someone who is in cardiogenic shock, but mostly who is hypovolemic in the hypovolemic shock, usually these are people with a high adrenal tone. They have high arterial tone. And by using norepinephrine, you won't be able to decrease the amount of fluids you are dealing with. So there is a strict separation between septic or anaphylactic patient. So using norepinephrine is not also, so the choice for norepinephrine is not only because it's a good substance, we can use it peripherally, it's also the question of safety. I've told you we will talk about safety quite a lot. That's a lovely article coming from United States. There was a period of shortage in norepinephrine. So the doctors need to use, or they had to use some other substances. So you see nicely that there is a drop in the amount of patients exposed to norepinephrine. And mostly the norepinephrine for treating septic shock was replaced by phenylephrine, which may be, a clever idea for some point of view. You got alpha, like vasoplegic patient, you will use alpha mimetic drug, something which is more alpha mimetic than norepinephrine. This should actually work. But when they analyze the data, and then it's in a retrospective analysis, so you should never like that's hypothesis generating. So you are not sure about this, but the numbers are pretty indicative. Those who received phenylephrine have much higher risk of mortality in septic shock. So the idea that you will use something which is more vasoconstrictive in a shock, so more alpha mimetic in septic shock, somehow not working, seems not to work. The reason may be in the fact that phenylephrine has almost a negative effect on contractility. It has no effect on beta, so it's a pure alpha mimetic. And this is increasing afterload for the heart, and hence it's decreasing the cardiac output. So you actually decrease the capacity of the myocardium for the flow. So this is possibly the reason why phenylephrine is not a drug of choice. We know that norepinephrine is having an alpha mimetic potential, and this is another article published by Xavier Monet demonstrating that norepinephrine by itself is also increasing, has the beta mimetic potential, is increasing the contractility of the heart. So it has the best profile in terms of alpha plus beta mimetic activity. So when we have the line of the catecholamine mimetics going to the left in septic shock and sepsis at the base of our patient, it's not the wise idea. So what's if we go to the other direction? So why not to use something more supportive for the heart? Historically, we've been dealing with dopamine, and sometimes you still may see that some people use dopamine as an addition in sepsis or a replacement in norepinephrine. Actually, this is the study by Daniel De Backer comparing norepinephrine to dopamine in treatment of shock. And you can see that basically there was either no difference between the patient's dopamine and norepinephrine, or there was higher mortality in the dopamine group. So these are, and this is more pronounced in patients with cardiogenic shock. And in the meta-analysis published by Daniel Backer and some colleagues later on, is further supportive to the fact that dopamine is having more side effects in these patients. And if you go even further on to the right, if you use epinephrine instead of norepinephrine, then you may have much higher risk of cardiogenic shock, of refractory shock, or of a cardiovascular mortality increased by arrhythmias mostly. And this is dictated by the fact that dopamine and more epinephrine and the beta mimetics are increasing the consumption of oxygen by the heart. And usually in septic shock patients who have a poor diastole, who have a high heart rate, the increase in consumption of the oxygen within the heart may be a risky situation. So not even on the right side. So if you will make a U-shaped curve, what's the best? Norepinephrine will be the drug with the least risk among the catecholamines. And what about the other drugs? What about vasopressin? We discussed that on the side of the pulmonary vasculature, vasopressin may be better. so may improve the pulmonary circulation. So we have only limited data on vasopressin. We have the Vanish trial comparing the noradrenaline and the vasopressin first. So the first admission, the first drug, and there was no difference among these drugs. So from this point of view, we may use vasopressin as a first-line drug. It will be, let's say, from the point of view of reaching the target of the mean arterial pressure may be the same. Vasopressin may be administered peripherally, but there is a higher risk of ischemia when using vasopressin. So it's the risk of ischemia, especially gastrointestinal ischemia, is almost twice as high by using vasopressin. And you see on this question of safety by James Russell trial or a redo trial of the previous large randomized trials that the dopamine is increasing the risk of arrhythmias. Vasopressin is increasing the risk of ischemia or peripheral ischemia. So this is the reason why norepinephrine has a better safety profile, and we should consider it the most safe drug in the shock. But what to do when the patient becomes refractory? You have your septic patient, maybe the same lady we had before, you got it in the ICU, she receives already a lot of fluids, she is on 0.4, 0.5 microgram per kilogram minute norepinephrine, receiving corticosteroids. So what we may do with this lady at this very moment? So we may go on with norepinephrine, or we may start adding other drugs, because we may say that 0.5 norepinephrine, it's an unresponsive patient, or we are reaching the responsiveness of norepinephrine. So first of all, you know that there was the discussion on the dose of norepinephrine, whether to use 0.2, 0.5 as the level for resistancy. And we know today we should discuss this in a norepinephrine base equivalence. I don't know how in Hungary, in Czech Republic, we are having tartrate. So actually, when we are speaking about the dose of norepinephrine, we are actually having twice as much in the calculation than the norepinephrine base. In Austria, in Germany, sometimes they use norepinephrine hydrochloride. So it's only a 1.2, like it's divided by 1.2. So it's important, and we should speak about the base. I am referring 0.4 in the tartrate. So you are having a patient with 0.225 microgram per kilogram a minute in the base. So that's important issue. Another important issue, if your norepinephrine is not working, is to look into the pH. So what's the acid-base state of your patient? Because important is that adrenergic receptors are pH reliable. So they respond on the pH. And if you have a severe acidosis, then while correcting slightly the acidosis, you may increase the sensitivity of catecholamine receptors to adrenergic substances. So that's an important issue also in the moment when you have a non-responsive patient. But if you solve all this, you should consider another vasopressor, because you reach the first line of responsiveness. And we know from the guidelines that this is really the moment when we should start considering vasopressin as the line 2 substance. Important on vasopressin, it has the V1 and V2 receptor agonisms of 1:1. V2 is antidiuretic response, V1 is vasoconstrictive response, and it is having a short half-life. When we add vasopressin at this moment, we have at least a signal of improvement in the patients, and it works in a lower shock severity better. So while reaching the 0.25 base, 0.3 in norepinephrine base, you should start considering adding vasopressin. Another issue with vasopressin is that you may have patients, you will start the drip of vasopressin and it's not working. We know from literature that there are patients vasopressin unresponsive. And quite interesting was the Valor study, a Japanese study published recently. They even found that among their patients, 1/3 of the patient was vasopressin unresponsive. So potentially this may be a quite like a percentage of our patients not responsive to the vasopressin. They've tested this by an initial bolus of 1 unit of vasopressin. I personally do not recommend this practice. It was done in this study. It's usually coupled with an hypertension, and I really think it's better to start a drip of vasopressin. But it may happen to you that you started vasopressin and it's not working. You may have a vasopressin unresponsive patients. What to do with these, or what to do in the situation when you don't have vasopressin? So previously, I believe Angor is the same. We have the terlipressin, and we use terlipressin instead of vasopressin in septic shock. We are still using terlipressin for the treatment of gastrointestinal bleeding induced by varicose bleeding. Important is that terlipressin is twice as powerful as vasopressin. It is much higher vasoconstrictive potential, and which is more important, it's a prolonged half-life and active metabolize. So once administered terlipressin, you have the vasoconstriction for a long period, almost 6 hours. And this is translated into outcomes. So the outcomes of vasopressin of terlipressin are basically very similar to vasopressin if you titrate, but it's very difficult to titrate something which has a 6 hours half-life, and therefore there is a much higher risk of ischemia as in severe adverse event, and definitely this is something we should not use if we have vasopressin at hand. Okay, let's discuss a patient when we add more. We are having vasopressin and we are still increasing the norepinephrine dose. Definitely a patient which is very likely to die. So that's the high risk population. Some authors do recommend to try to add adrenaline in this moment because, and especially in patients who are on previous beta blockade, norepinephrine may act more like phenylephrine. So the line of the catecholamine mimetics may be shifted to the left. And actually the epinephrine will in these patients act more like norepinephrine normally because the heart is beta blocked. So you need a more competitive agonist on the heart. So what you can test, and that's good on adrenaline or epinephrine if you wish, is that it's again a drug which is on and off effect. So you may try to test, to do a treat challenge with a small amount of norepinephrine, adding epinephrine to the norepinephrine. And if you add the same amount, like same concentration, same dilution of epinephrine, you start with this and you see that your norepinephrine is decreasing more than what you add in adrenaline, then you have someone who is adrenaline responsive. But mine would be told about adrenaline. You are increasing the risk of arrhythmia. You are increasing the risk of oxygen consumption by the heart, but maybe here, so it will have potential cost for your patient, but maybe it will work better. You will be able to wean the vasopressor. Other potential, which is quite recent, is angiotensin. I won't go more in deep with angiotensin because I don't have any personal experience with angiotensin 2. It's kind of new drug. And again, we discussed this. It's the drug going on the same effector pathway as the V receptors and alpha-1 receptors, but it seems it may work, and it seems it may be renoprotective, especially in high severity shock. But we need more data on this. So if I should sum up this part on recommendation how to use vasopressors, I really invite you to find out this article by Thomas Sheeran on the current use of vasopressors, and you have a summary of what we've been discussing, that norepinephrine is definitely the drug of choice, what are the targets, and that adding vasopressin may be the good recommendation. And what about inotropes? You may have this same lady a few days after with this picture. So you have a drop in cardiac index. You see that there is an increased global and diastolic volume, and what you see is septic cardiomyopathy, drop in global ejection fraction. So what to do in the case your patient is actually in a decreased cardiac index? So what to do with these patients? You may add inotropes, and we've got different sort of different inotropes. We've got dobutamine, we've got adrenaline, we've got milrinone and levosimendan. Basically, these 4 drugs are in the shelf for us in the moment. The guidelines give you 2 possibilities: either adding dobutamine or switching or adding epinephrine. The experts are more in line with adding dobutamine. The reason is already discussed. Epinephrine is decreasing the risk of cardiovascular mortality, even though the data in septic shock comparing norepinephrine plus dobutamine, so adding a drug which is a beta mimetic on one side and converting to epinephrine, don't point toward one or the other. So we have a lack of data in here. So you can use one or the other. It seems it both will work in the same costs. But there is the fact that epinephrine is increasing the consumption of oxygen. We have some data between the inotropes from cardiogenic shock. The data from septic shock, septic cardiomyopathy is very rare. I will show you later on. It's very rare, so we don't have any kind of randomized control data or very small amount of randomized control data. We have more in cardiogenic shock, which is from the very beginning, low cardiac index, low flow state. And here, milrinone or dobutamine seems to be the same. Actually, if you just, I will just remember you on the graph in the beginning. If you add dobutamine, it's beta mimetic. If you get milrinone, you increase the CAMP concentration, which is actually the same effector pathway. In both these drugs, you got a high risk of arrhythmias. The difference, which is that milrinone has a double effect on the vasodilation in the periphery. So from the point of view of the heart, there is no difference. What about septic shock? This is a really lovely study. They screened 38,000 patients, and they ended up with 200. So this is what you will look, that's the picture, the epidemiology picture of sepsis cardiomyopathy. It's extremely rare. So I believe we will never have a good data in here. But if we look in there, there is no difference between dobutamine and milrinone. So one or the other, basically the same data. What about levosimendan? You know that there is this Leopards trial. No difference. Again, maybe we can talk about the fact that this were not a good indication that all the patients with sepsis were included, and not only those 200 out of 40,000. Very difficult to do. But we know that the levosimendan is actually not helping the cardiac surgery as well. So when we do this in line, we see that there is no big difference between the drugs. Where we have seen a difference is in those 1 beta blockers previously. So again, if you have blocked the pathway of the beta blockers, the dobutamine won't work, then the levosimendan may be working. So to sum up the inotropes, levosimendan is definitely not the one which should be used as a primary drug for these patients. It also have a long-term effect there. If you start levosimendan, you need to wait for the effect several hours, and the effect of levosimendan lasts for days. So maybe this is it's good for patients who are on beta blockers. Maybe it may work in these. It may work in Takotsubo syndrome, for instance. So in terms of recommendations for inotropes, we will start with the not enough data statement. So most of this is, let's say, a recommendation based on the expert opinion. And the expert opinion states that the first drug to use is dobutamine. Maybe because it's on and off drug, it's very short onset, short acting. Unlike milrinone, unlike levosimendan, it's really fast. So that's a test drug, you may say. The indication to start inotropes in any kind of shock state is low cardiac output, which means you measure cardiac output in any way, either using echo or using hemodynamic monitoring. And I zoom up and end here. So if you would like to read more, you got 3 papers in here, which I really invite you to read. All of them are open access. So you can read the recommendation, the consensus recommendation for use of vasopressors in shock, to use inotropes in cardiogenic and any kind of circulatory shock. And I thank you for the invitation, and I end up. Thank you.
Thank you, Jan. Can you hear me?
Yes, I do.
Excellent. So, unfortunately, we are running out of time. We have a meeting at 5. So, what is your trigger for starting advanced hemodynamic monitoring? Because this is something you did not mention, that you go up with your vasopressor, you add vasopressin, you add dobutamine, but when will you switch from standard monitoring to advanced hemodynamic monitoring?
Joel, thank you very much. Excellent question. Actually, it was visible in the slides. You know, usually the moment we consider the patient refractory to the initial treatment, which means fluids plus the initial dose of norepinephrine. Usually when we hit the 0.5, 0.3 up to 0.8, somewhere there in the tertiary dosage. So then we consider the patient to be non-responder to the initial treatment. And in order to distinguish between those needing more inotropes or adding vasopressin or any other drug, we usually, in my point of view, we need more information. And this is something echocardiography plus hemodynamic monitoring can only give us. So that's the moment.
Yes, and the reason why I'm asking, because we had kind of a debate with Jean-Louis Vincent on the term refractory shock, right? So this is not very well defined. So it is still quite an arbitrary decision of yours and mine, what we call refractory. But your decision is quite sound, and I think that is a safe approach to define being refractory at such a low vasopressor requirement.
Honestly speaking, you know, it's in the consideration. It's not only in order to say this is refractory state, it's not only the dose of norepinephrine. You know, I take into consideration the amount of fluids, how fast the load is, how fast the dose is rising. If you have someone who you start norepinephrine and after 1 or 2 days you reach this dose, that's non-refractory. Okay, you know that you are almost hitting the plateau and you will go down. That's okay. But if you started treatment and immediately you are there and you see you increase each 10 minutes, you increase the dose, then it's refractory. And the same is, for instance, for the initial diagnosis. So that's also important. What's the baseline setting of the patient? If the patient is previously healthy, I will possibly wait a bit long. And that's, for instance, he was healthy, it's a trauma, and I need to give him fluids, and I have the vasopressor as, let's say, an additional treatment, then I will possibly wait longer. If I have a septic case in someone who is with a chronic heart disease, then the trigger for issuing hemodynamic monitoring and setting the label refractory will be lower.
This just confirms that there is no replacement at the moment of a thinking, well-trained, experienced physician at the bedside, correct?
Yeah, absolutely.
Patients still need us. So thank you very much, Jan. It was great. The video will be available within a couple of days, possibly tomorrow on YouTube. So thanks again. And I also would like to thank the Translational Medicine Center for Translational Medicine, the Semmelweis University, and the Department of Anesthesia and Intensive Care to make this venue and event possible. And a special thank to Jan Benes. And see you in 2 weeks' time. Thanks a lot. Bye.
Okay. Thank you for the invitation. Goodbye.